Hello, this is Jason Jones, and in this video I'd like to describe a recent challenging and complex case that was in my operating room. This patient had a recent vitrectomy 5 months prior for a vitreous hemorrhage, which was found to occur due to a retinal tear. I noted here the posterior capsular cataract, and you can see a rather unique appearance here, which to me indicated a potential perforation might have occurred. I created my usual capsulorhexis of approximately 5 millimeters or so. I want to ensure that I can perform optic capture if need be. And then I go to a hydrodelineation technique to help mobilize the nuclear material. It's important to try to avoid hydrodissection in these cases, although some may inadvertently occur. The goal here is to avoid extending any posterior rent. Now this is a low flow setting, and I'm going to groove centrally here rather deeply to achieve a nice fairly wide central trench, and then a cracking maneuver is achieved through that posterior plate. This hemisection to the right is fairly readily chopped and mobilized using a little bit more aggressive but still moderated fluidic parameters. Each piece is then efficiently emulsified. My goal here is to have as few pieces as possible so that if a larger rent does occur, I can more readily manage individual pieces of material, and I may be able to avoid posterior descent of any nuclear material if it does open up on me posteriorly. This is a fairly dense nucleus, and it is in contradistinction to a more intumescent cataract which might occur if a larger perforation were to have happened. To note here, I've gone to a blunted second instrument to help guide these pieces to my phaco tip, and I can be more posterior with that instrument in a very safe fashion. Viscoelastic then tamponades the anterior chamber as I remove my irrigating instrument, and then using a dispersive agent I'm going to initiate viscodissection to help mobilize the cortical material from the capsular bag. I find it's easiest just to proceed with as many normal maneuvers as possible, and here I've continued with my coaxial irrigation aspiration handpiece. As I'm working towards this area of potential perforation, I'm being more gentle, but I'm also using a mechanical dissection technique with the tip of the IA. Once again, with some dispersive agent, I'm going to mobilize more of this material centrally. And going to a bimanual technique permits better access to all areas of the capsular bag, especially given the difficulty I've had here in mobilizing this material. You can see here this mechanical blunt dissection using the aspiration handpiece of the bimanual IA and liberating this material from the fornix of the capsular bag very efficiently. It's also very reassuring to see the posterior capsule still remains fairly intact, but here we can see the area of potential perforation exposed. This more epinuclear material is just coming off in sheets and lamellae, so it is tedious to perform its removal, or the cortex removal is direct from the capsular fornix using the aspiration port. Now that this more dense epinuclear and cortical material is liberated, it comes out more rapidly. I'm going very slowly though. I want to avoid any undue potential traction if there is any vitreous that could come forward. It's always better to assume that there is vitreous present even though this patient has had a posterior vitrectomy. You can see here, I can drop this viscoelastic right through that that opening. So indeed there is an opening, and there is no vitreous there to prevent its posterior descent. And polishing the posterior capsule convinces me there's no way I'm going to get this material to really liberate. And I want to make sure I have a nice stable situation for my intraocular lens. So I'm going to perform a posterior capsulorhexis. Now it's interesting to see here, I've perforated the capsule, created a flap. Now I'm going to open the flap a little bit larger. And note here, as the viscoelastic, and this is cohesive agent, goes posterior to the capsule, that it doesn't drop posteriorly. So there is still a thin sheet of vitreous that is present here. And I could tell that as well during the surgery, as there was some specks of pigment within that vitreous material still. It is difficult to visualize on the video. And the technique here is balancing this tension across the capsule to create a viscodissection wave. And by balancing the tension, you gain better control, and you don't have the opening that you've created run out. It's important here to incorporate the perforation within the posterior capsulotomy. And with viscoelastic in the eye at this point, both behind and in front of the posterior capsule, this is a very safe maneuver. Now we have a continuous tear posterior capsulotomy, and here is that posterior capsule. You can see the perforation quite nicely. I've checked my wound here just to ensure there is no vitreous. I don't see any movement of the capsular membranes, and some additional cohesive agent is placed in that capsular rim. Your new lens is going in. A single piece of acrylic lens is inserted using an injector system through an unenlarged 2.4 millimeter wound. I have my tech screw the injector as I help to guide it using my second instrument, and use essentially a wound assist technique. Now the lens is in the capsular rim, and my preference here is to perform a posterior optic capture. And you can see this cat eye formation of the posterior capsule. Viscoelastic is then evacuated, no wounds are secured. This patient had an excellent result. This case readily demonstrates that it is paramount to be vigilant when we have patients who've had previous surgery, and we can achieve a successful result. Thank you.